Kindly be seated. We'll soon be starting with our inaugural program. I request the delegates to please come inside the hall so that we can start our inauguration program. Ladies and gentlemen, I request you all to please be seated. Yes. Thank you so much. So good afternoon, ladies and gentlemen. It is our pleasure, pride and privilege to welcome each and every one of you to this 13th annual Sir Gangaram Hospital CME. The words of St. Francis Bacon, knowledge is power, epitomizes the essence of the CME. But today we come together not only to share knowledge and exchange ideas, but also to form new bonds of friendship, which will endure through the years. It is our absolute pleasure to welcome each one of you here this afternoon, because you all bring your individual perspectives, your enthusiasm, your expertise to this gathering, and we welcome you. It is truly wonderful to see some old familiar faces and lots of new ones here today. And I thank you all for your presence as we learn, explore, and grow together. So before we begin, I would like to invite to the stage our dignitaries who are there with us. I welcome Dr. Arun Gupta, President of the Delhi Medical Council, who is about to reach. Dr. Girish Tyagi, the Registrar cum Secretary, Delhi Medical Council. Welcome, sir. Welcome. Do join us on the stage. Dr. Anil Bhalla, Secretary, Board of Management, Sir Gangaram Hospital. Welcome, sir. Dr. Jayashri Sood, Vice Chairperson, Board of Management, Sir Gangaram Hospital. Dr. V.K. Malik, Dean Gripma. Okay. And Dr. Harbans Lal, the Chairman, Department of CME. I welcome you all onto the dais. Ladies and gentlemen, we have today with us Dr. Anil Bhalla, Secretary, Board of Management, Sir Gangaram Hospital, who has been a guiding force for the hospital, a man of vision, dedication, and unwavering commitment to excellence in healthcare. I now invite him to deliver the welcome address. Sir.
Good afternoon to all of you. Dr. Girish Tyagi, Madam Jayashri Sood, Dr. Harbans Lal, Chairman CME Committee. Ladies and gentlemen, we welcome Dr. Arun Gupta. Please, sir. Dr. Arun Gupta, the President of Delhi Medical Council. Dr. Girish Tyagi, Secretary, Registrar of Delhi Medical Council. Ladies and gentlemen, it is my proud privilege and great opportunity for me to welcome all of you to this 13th CME. On behalf of Board of Management of Sir Gangaram Hospital and CME Committee, which is headed by Dr. Harbans Lal. This conference provides an excellent opportunity to hear and learn from the speakers and experts in their field, and talking about the various medical topics. And actually, it is an exchange of ideas. One is that we see a lot of old familiar faces and plus we see a lot of new faces also. Similarly, as a motto of Dandaram Hospital is the strong academics, research and teaching, where we have more than 43 DNBs and fellowships running at our hospital. That means the teaching is a main part of one of the main activity of Dandaram Hospital. So in continuation of that activity, we have been running this CME, and the best part of the CME is that we have all the specialties in just about 1 day activity, and we have a brief discussion about all the specialties. So for a GP, for a primary care physician, it is very important to know what is happening around, because there is a so rapid medical breakthrough going on at the pace, and medical knowledge and technology both are interlinked now. And now we know the artificial intelligence, how it is going to impact our decisions and treatment. That is one aspect, and other is that we as a Dandaram Hospital, we also constantly are going to keep on upgrading our facilities. And the latest is the complete onco-wind with onco surgery as well as radiotherapy, which is going to start in next March and or April. So it will be a great opportunity to interact with all of you so that you can utilize the services here. Apart from this, you have a occasion where you can have networking with the consultants of Dandaram Hospital. And I have just given 2 ideas to Dr. Harbanslal that we must have a WhatsApp group also of this CME who are regularly attending. And another is we like to have your feedback also after the completion of CME, so that we can introduce new topics in the next CMEs and have your feedback how we can improve further. With this, I wish this CME a grand success, and I look forward to your active participation. Thank you.
Thank you, sir. We also have with us today Dr. Jayashri Sood, Vice Chairperson, Board of Management, Sir Gangaram Hospital. A keen academician, her achievements always inspire her, and her warm persona and aura add that special something to every occasion. So I now welcome Dr. Jaya Sood and request her to deliver the inaugural address.
Thank you, Dr. Tinku, for those kind words. Good afternoon, everybody. Dr. Arun Gupta, the President of the Delhi Medical Council, the Chief Guest of the CME today, Dr. Girish Tyagi, Secretary cum Treasurer of the Delhi Medical Council, the Guest of Honor for the CME today, Dr. Harbanslal, Dr. Anil Bhalla, and Dr. Tinku, and all our senior faculty who are here, the delegates who are attending the function, a warm welcome to all of you. It's my proud privilege that we are hosting the 13th annual CME today along with the DMA. As you all know, our hospital is situated in the heart of New Delhi, but way back in 1921, that was the time our founder, who was a chief engineer, civil engineer, and a philanthropist, who started the Sir Gangaram Hospital in Lahore in 1921. That was when the foundation stone was laid. And it was after partition that this Sir Gangaram Hospital foundation was laid in 1954 by the then Prime Minister Jawaharlal Nehru. Since then, we have grown a lot. And as you just heard, that now we are a 675-bedded super specialty hospital with cutting-edge technology and faculty which is experienced in their fields. Very soon, we are going to become an 800-bedded hospital with additional facilities, and now we will be a fully dedicated oncology, oncosurgery center, which we were lacking a little bit behind. Our hospital is unique because we have a cross-subsidized model in which we say it is a general population's own hospital where the richer actually subsidize and they pay for the weaker community. And this is the way how we function. Since we are very interested in education and research, this is how the idea of the annual CMEs for the general practitioners was started. And Dr. Harbans Lal took the lead, of course, by the permission of the Board of Management, which runs the hospital, and he has been doing a very perfect job. And I think except for the COVID, we've had it regularly every year. And today, of course, we'll be having the 13th annual CME that is going to be conducted today. I must compliment the Board of Management compliments Dr. Harbans Lal and his team, which includes Dr. Tinku, a very important member, for conducting this. And we put it on record by the board. The trustees also appreciate the efforts of our hospital activities. It's very interesting that I believe that the doctors who attend this as delegates had requested Dr. Lal that we should have this program in 2 halls. And today, as you have seen, we've been running 2 consecutive halls at the same time. Plus, this is being showcased on the Facebook and the YouTube, which is commendable. So that's a great feat for our IT and our hospital. So I wish you all a very happy CME today, and please interact with the seniors and the faculty so that you can gain the best. Thank you very much.
Thank you, ma'am, for your words of welcome. It is my pleasure now to introduce our esteemed guest of honor for today's CME, Dr. Girish Tyagi, Registrar cum Secretary, Delhi Medical Council, who has a wealth of experience and expertise. We extend a warm welcome to you, sir, and invite you to share some insights and words of inspiration for us.
Thank you, Dr. Harbans Lal and team. Dr. Arun Gupta, President, Delhi Medical Council and Chief Guest for today's program. Dr. Jashi Sood, Vice Chairman, Board of Management, Gangaram Hospital. Dr. A.K. Bhalla, General Secretary, Board of Management, and a fellow member of Delhi Medical Council for 3 to 4 years, and a good friend of ours. Dr. Bayatra, and other dear friends, Dr. I.P.S. Kalra and Singh. First of all, congratulations, Dr. Bhalla, for organizing this CME, because this Gangaram Hospital CME members wait for years, months to months for this conference, because it is a very good conference in a way that members get benefited out of it, and topics are of general practice and all the specialties are also for that matter. As far as the Delhi Medical Council, since I am at Delhi Medical Council, we receive complaint against the doctor for their professional misconduct and negligence, and number of complaints are increasing day by day. At the moment, we got around 50 complaints per month. That means 2 to 3 complaints per day we are receiving against the doctor for professional misconduct and negligence. And 60 to 65% of the complaints are not because of medical negligence or issues, but because of other issues like communication, behavior issues, or financial issues, for which the doctors is not at all concerned with that treatment. Suppose a nurse is not satisfactory behaving with the patient or the relative, or nursing orderly or sweeper of the hospital, they file a complaint against the doctor for that professional misconduct or negligence. Apart from these, issues like communication, documentation, which we, myself and Dr. Ankita, wherever we go, we are stressing on these issues, because communication is the part, and 70 to 80% of the complaints are against the doctors are because of the communication only. Because we, as doctors, we don't try to communicate properly with the patient or the relatives, or just we inform them whatever we want to convey them. We are not listening to them. Communication should be a two-way communication. We should give time to patients, give them liberty to ask questions, try to solve those issues. Because nowadays the patients are aware ones. Gone are the days when patients are illiterate or now they are coming to the doctor with preparedness, with their colleagues or some doctor friends or some relatives friends, and so communication should be two-way communication and communicate. There are two things in the communication: communicate effectively to prevent error. That is with the team members, because most of the time it is seen that we doctors are not communicating with our team members even. Most of the time the patients are being treated by a multidisciplinary team where the MD medicine, neurologist or nephrologist or other specialties are also there, and we are not communicating with our other team members also. MD medicine is not talking to nephrologists or neurologists. They are coming at different times. Sometimes they are documenting, sometimes they are not documenting. So patients get a higher dose, lower dose, or sometimes dose is missed, or we are passing verbal order to the nurse also. So communicate effectively to prevent error, that is with our team members, and communicate effectively to prevent dissatisfaction, that is with the patient and the relatives. If we are communicating effectively with the patient and the relative, likelihood there will be less chances of dissatisfaction. Once the chances of dissatisfaction are less, likelihood that they will not file a complaint against the doctor. So communication is a very, very important part, and previously it was not a part of the curriculum, but series of meeting with the health ministry and that National Medical Commission or Medical Council of India, now it has been the part of the curriculum, because we don't know how to disclose the bad news, how to disclose the death to the patient or to the relatives, how to disclose that we are not for that. And sometimes because of these issues, complaints are being filed, because if the doctor smilingly telling the relatives that such and such patient has expired, they will not accept that. If the doctor is telling smilingly. So communication is effective. More so with the documentation part. Documentation is very, very important, and we as doctors are very poorly in the documentation part. And documentation is important not from that it is a legal or ethical requirement. It acts as a evidence. Whatever you are writing in the records is a thing which will decide your fate in the particular case, whether it's the State Medical Council, National Medical Commission, Consumer Court, Criminal Court, etc. So conviction of that particular doctor with a particular case will be decided based on that part of the documentation part. And we have seen that documentation, we thought that documentation is just a formality. It is not a formality, first of all. In the documentation, more important is the consent part, because I request everyone in the hall to go through the NMC Regulation 2023. Why am I stressing on that? Because these NMC Regulation 2023, which are at the moment are kept in abeyance, but maybe in a few days, a month, they will come into force. And now this, with every professional misconduct, there is a level of punishment attached with these misconduct. Previously in the IMC regulation, only that professional misconduct was there, but there was no level of punishment attached. Now with these NMC regulation, there is a five level of punishments are there. Level 1 punishment is there when the State Medical Council will give a warning or advisory to that pattern. Level 2 punishment is your name can be removed for 30 days. Level 3 punishment is your name can be removed for 3 months. Level 4 punishment is your name can be removed for 3 years. And level 5 punishment is your name can be removed for month removed. So level 4 punishment, I am talking about that consent part, because if the consent is not proper, proper, your name can be removed for 3 years. And we as doctors, more so the surgeon part, we are taking consent just a piece of formality, just a piece of paper. It is not a formality, it is not a piece of paper. If the consent is improper, that means improper means you have to tell the patient about that procedure part, you have to tell the patient about that complication, you have to tell the patient about the alternatives, you have to tell about the benefits, you have to tell the patient about the risk involved if he refuses that treatment. That has to be told and it has to be documented. So we have seen that the consent, sometimes consent is a blank. It is, of course, it is improper. Sometimes consent is taken by a minor son, automatically it becomes a invalid consent. If the patient is of sound mind and a major patient has attained of 18 years, consent has to be taken from the patient himself only. Not spouse, not father, not relative, not friend can sign the patient on his behalf. That is rule. And nowadays, if the consent, once NMC regulation come into force, If the consent is found to be invalid, your name can be removed for 3 years, whether the negligence proved or not. So, consent printed in English, and the patient putting a thumb impression on that English printed consent, it automatically becomes invalid consent. Automatically becomes invalid. Because the patient always realize that हमें तो बताया ही नहीं गया, हमें तो हॉस्पिटल पहुंचे, सीधा जाके स्ट्रेचर पे लाया, कैथ लैब में ले गए और वहां पे जाके साइन कराए. तो दीज काइंड ऑफ एलिगेशन विल बी देयर. सो यू हैव टू टेक द कंसेंट, प्रॉपर कंसेंट. इट हैज टू बी डॉक्यूमेंटेड. आपने उसको बताया नहीं बताया उसका फर्क नहीं पड़ रहा, बट इट हैज टू बी डॉक्यूमेंटेड. ऑफ कोर्स द पेशेंट विल अराइव, बट इफ ही हैज साइंड इफ द पेशेंट इज इलिटरेट, ही कैन आस्क द पेशेंट टू राइट इन हिंदी इन हिज ओन वर्ड्स कि मेरे को बता, प्रोसीजर के बारे में बता दिया गया है, मेरे को कॉम्प्लिकेशन समझ लिए हैं. ट्राई टू write some complication on that part. If the patient is totally illiterate, try to get a signature of independent witness, not your nursing orderly or nurse on that consent part. That is very, very important. So consent documentation is very, very important. Apart from these, NMC, just go to the NMC regulation 2023, because as you have to, on every prescription, on every inpatient or on part, you have to write your name, signature, registration number along with the stamp. This is an NMC regulation. Once this notified, it will become a law. At the moment, they are kept in abeyance. So, if your name is not there, or signature is not there, or stamp is not there, your name can be removed for 30 days. It is a level 2 punishment. So, with every prescription, you have to. Why this is there? Because most of the time it is seen that the doctors are not putting the signature. In our Delhi Medical Council hearing, also we have come to know that we are in the hearing, we are asking, we are not able to read those notes. They have not put their signature. Hospital is not able to identify who has put up those notes. So these kind of issues are there. So because of that, now these things have come into force as a law. We have to be very careful for that matter, and just request to go through those NMC regulation 2023. Again, I'm telling you. Few more about that medical certificate. Recently, we are getting number of complaints against the doctor for issuing the false medical certificate for relief of money. In one of the medical certificate, which a MBBS doctor issued, husband of a lady went to a MBBS nursing clinic. He didn't brought his wife. He told that doctor that my wife is very agitated and she is depressed, and just refer to GB Pant Hospital for expert opinion. Doctor, without examining that lady, issued a medical certificate on the prescription. He writes that such and such patient is suffering from manico-depressive psychosis. Refer to GB Pant Hospital for admission and management. Of course, there was signature, stamp, etc. When this case came to us through the court, when the disciplinary committee, we asked the lady to come. Lady was there. Dr. Arun is there. She weepingly told that because of that prescription, that husband of that lady filed a divorce petition in the court. Without examining that lady, he wrote that lady is suffering from manico-depressive psychosis, and husband used that prescription in that divorce petition. So action was taken against that doctor for that matter. And we are getting number of complaints like that. In one of the case, a doctor, he was also a MBBS doctor, give a medical certificate for 9 months to a person, because he also wrote that manico-depressive psychosis for that matter, and चलो सर्टिफिकेट दे दिया. That person uses that certificate in the court for exemption of the appearance. कोर्ट ने हमारे को भेजा, उसमें of course 9 month certificate he cannot give. In the reply to Delhi Medical Council, when we asked that doctor to file a reply to Delhi Medical Council, उसमें doctor reply क्या करता है कि he was seen on such and such date and he was depressive, he was not interested in the atmosphere, other surroundings and all. Plus one line which he wrote, that he has a suicidal tendency. 3 times he has attempted hanging. he has given in writing to Delhi Medical Council. A person who has a suicidal tendency, who has attempted 3 times hanging, and that MBBS doctor is giving a medical certificate for 9 months without referring to a psychiatrist, psychologist, or any hospital. So, and because of that code sent to us, so action was taken against that doctor also. So we should be careful what we are writing in that. In the reply, himself he is writing कि पेशेंट को सुसाइडल थी, 3 बार उसने अटेम्प्ट कर लिया. अगर सुसाइड का पेशेंट एक अटेम्प्ट कर रहा है, हैंगिंग अटेम्प्ट कर चुका है 3 बार, उसको एमबीबीएस डॉक्टर अगर अपने पास 9 महीने तक गलत या सही की बात ही नहीं कर रहे. और इनफैक्ट व्हेन वी आस्क्ड द डॉक्टर टू प्रोवाइड अस दैट OPD record that he has seen the patient, he told that he is not maintaining those medical records. So nobody will admit such kind of reply from a doctor that he is not maintaining a report, giving the medical certificate. So these kind of issues are very, very important. It is not we are just try to scare you about that. Just do the ethical practice. If you are examining the patient, if he requires a test, you can always give. But giving a medical certificate in lieu of the money is not acceptable at all. Because in one of the cases, medical certificate was issued for 8 to 9 months. The disciplinary committee, because we have in the disciplinary committee, we have 6 members. Out of these 6 members, 3 are non-medical persons and 3 are medical persons. 3 non-medical persons is one MLA is there, one medical, one lawyer is there, one eminent public man. These are the 3 non-medical persons in the disciplinary committee. In the disciplinary committee, we asked that जिसने medical certificate उसको दिया था 8 to 9 months का. First thing is give us the record. He was not maintaining any record. Then हमारे जो MLA साहब थे उन्होंने कहा कि डॉक्टर साहब हम तो जो हमारा कॉन्स्टिट्यूंसी में किसी को मेडिकल सर्टिफिकेट की जरूरत है उस डॉक्टर का भेज देते हैं, वो अपना 10 रुपये पर डे के हिसाब से दे देता है और इस हिसाब से मेडिकल सर्टिफिकेट मिल जाता है. MLA साहब ने उस डॉक्टर से बात की, डॉक्टर साहब आपने भी कुछ इस तरह से करा होगा. पहले ही टोल्ड नो आई डोंट डू सच काइंड ऑफ प्रैक्टिस. देन ही टोल्ड कि हाँ सर वो था, उसको दे दिया था. उसके बाद इफ अ डॉक्टर इज एडमिटिंग इन फ्रंट ऑफ नॉन मेडिकल पर्सन्स, MLA, लीगल मेंबर एंड एमिनेंट पब्लिक मैन, दैट ही इज इशूइंग अ मेडिकल सर्टिफिकेट इन लिeu ऑफ द मनी. उसके बाद MLA साहब ने उसको कहा कि डॉक्टर साहब हमारे आपने इसको 9 महीने का सर्टिफिकेट दिया, इतने तो आपको तो हिसाब से महीने के 3-4-2-3 लाख तो आप इसी से कमा लेते हो, कितनी तो हमारी कमाई नहीं होती. देन ही स्माइलिंग दैट डॉक्टर टोल्ड दैट नहीं डॉक्टर नहीं MLA साहब मैंने उसको कंसेशन भी दे दिया था. सो दीज काइंड ऑफ utterances in front of those non-medical persons, of course we have taken action, but the message is that what we are message giving to those non-medical persons which are hostile to medical profession, चाहे MLA है, चाहे वो legal member है, चाहे वो eminent public man है, these all persons, including the police, media, etc., court, they are all hostile to our profession, and the message which we are giving to those non-medical persons that we are issuing, we are doing such kind of unethical, because what the message they are getting कि सभी डॉक्टर ऐसा करते होंगे. So we have to be very careful in dealing the patients, and lastly treat every patient as potential litigant in current scenario. चाहे आपकी भाभी का वो नॉन टू है, चाहे आपके ब्रदर का है, चाहे आपके फ्रेंड ने किसी का रेफरेंस लेके आया, ट्रीट एवरी पेशेंट एज अ पोटेंशियल लिटिगेंट. वी हैव द केसेस वेयर द वाइफ इज फाइलिंग अ कंप्लेंट अगेंस्ट हिज हस्बैंड, a brother-in-law filing his complaint against his jija. So we are not, these are not isolated cases, because these are usual cases which we are receiving at Delhi Medical Council, and my request is treat every patient as a potential litigant. He can file you, he can trouble you, and once a notice from whether a state medical council or income tax or CBI or police or court, आपकी रात की नींद गायब हो जाती है. अगर आपको रात को अच्छी तरह से सोना है तो बी केयरफुल एंड फॉलो एथिकल प्रैक्टिस एंड ट्रीट एवरी पेशेंट एज अ पोटेंशियल लिटिगेंट. थैंक यू वेरी मच.
Thank you, sir, for sharing your wealth of experience and highlighting some very important issues for us. Thank you so much again. It was a pleasure listening to you. It is also both our honor and privilege to have with us today Dr. Arun Gupta, a distinguished physician who embodies the spirit of innovation and leadership, as our esteemed chief guest. Dr. Arun Gupta is the President of the Delhi Medical Council and also an advisor to the Ministry of Health, Government of Delhi, NCT. Without further ado, I invite him to share his insights, thoughts, and perhaps some pearls of wisdom with us. Please join me in welcoming Dr. Arun Gupta. Welcome, sir.
Good afternoon, everyone. I would like to compliment the team of Gangaram Hospitals in two ways. First of all, in our council or even our medical fraternity, we always say that the Gangaram Hospital has the best faculty in Delhi. If whenever I need treatment for myself or my family or my friend, I always advise Gangaram Hospital. And you people, and secondly, you people are hosting such beautiful CMEs, and I happen to attend a lot of them, and the academic standard is very, very high. And one more thing, इसको लैक्सली मत लेना, पर सबसे कम केसेस हमारे पास गंगाराम हॉस्पिटल्स के आते हैं. तो यहाँ भी हम लोग एग्जांपल्स देते हैं कि गंगाराम से सीखना होता है, और कई बार केसेस आते भी हैं तो वैसे इनकी हार्डली एवर आर कन्विक्टेड है हॉस्पिटल, एनी डॉक्टर गंगाराम हॉस्पिटल. तो आप लोगों का डॉक्यूमेंटेशन, आप लोगों का मेडिकल ट्रीटमेंट बहुत अच्छा है. तो अगर बाकी लोग हॉस्पिटल्स में इसको एम्यूलेट करें तो काउंसिल का काम बहुत कम हो जाएगा. Ladies and gentlemen, it's my 9th year as a president of council. When I joined, I was getting almost 10 to 15 cases in a month. But these days I'm getting more than 50 to 60 cases in a month. Yeah, that really worries me. But more important than that, now litigants are much better prepared than they were earlier. आपसे ज़्यादा पढ़ के आते हैं. We are very good at medical science. We do all the CMEs. अभी भी डॉक्टर हरबंस को कह रहा था, आपने वो लॉ वाला लेक्चर क्यों नहीं रखा? I teach for 9 years. I've been teaching doctors about law applicable to medical science. आप लोगों ने कैसे मिस कर दिया? तो आधा घंटा का दे देते तो बहुत बेनिफिट था उसका. Anyway, so Delhi Medical Council is we are teaching all the CMEs and all the hospitals. We are going there and teaching me and Dr. Tyagi about the medical laws. तो ये जानना बहुत जरूरी है. और जो the cases which we are getting today, the patients and litigants are so well prepared, because medicine you prepare but you don't read the laws, and we never read the ethics governing us. आप इस हॉल में ईमानदारी से हाथ खड़ा करके बताएं कितने लोगों ने MCI कोड ऑफ एथिक्स पढ़ा हुआ है? ऑनेस्टली पूरे हॉल में कितने लोगों ने MCI कोड ऑफ एथिक्स पढ़ा है? 4 या 5. सब जगह ये हाल है सर, कुछ चिंता नहीं करो. जहां में 100 में से 2 या 3 लोगों ने पढ़ा था, और ये MCI कोड ऑफ एथिक्स गवर्न्स आवर एवरीडे प्रैक्टिस. इट गवर्न्स, इसमें जितने हॉल में मोस्टली मुझे 50-60 प्लस लोग नजर आ रहे हैं. तो 20-30 सालों से प्रैक्टिस आप लोग कर रहे हैं ना. और ये MCI कोड ऑफ एथिक्स 2002 में रिलीज हुआ था, 21 ईयर्स पहले, विच गवर्न्स आवर एवरीडे प्रैक्टिस. आप तो पढ़ेंगे नहीं, पर जो केस करेगा वो पक्का पढ़ के आएगा उसको. और ज्यादातर केसेस में हमने देखा है मेडिकल ट्रीटमेंट में यू डोंट फॉल्टर, बट यू फॉल्टर इन द एथिक्स. छोटी छोटी सी बातें आप उसमें लगेगा कि रजिस्ट्रेशन सबको पता है, करवाना चाहिए. सबसे बड़ी प्रॉब्लम मुझे आ रही है, आपके प्रिस्क्रिप्शन पे अपनी डिग्री को आप हाईलाइट कैसे करते हैं? यू कैन नॉट फ्लॉन्ट अ डिग्री विच इज नॉट रिकॉग्नाइज्ड बाय नेशनल मेडिकल कमीशन, एज सिंपल एज दैट. You cannot claim to be a specialist or super specialist unless your claim is backed by a degree from National Medical Commission. आप MD medicine cannot write cardiologist, he cannot write diabetologist, he cannot write. इस तरह के टीम नंबर एग्जाम्पल से आप कुछ भी लिख दीजिए. अगर केस में फंस गए तो जज सबसे पहले पूछेगा, वो कंप्लेंट बोलेगा, सर मेरे को तो लगा है तो कार्डियोलॉजिस्ट से मैं तो चला गया, ये तो MD मेडिसिन निकले. MD medicine can treat a patient of heart, but he cannot claim to cardiologist. एक एग्जांपल दे रहा हूं, आप बाकी अपने भी बात में सोच लीजिएगा. ऐसे बहुत से केसेस आ रहे हैं जाके डॉक्टर्स आर लूजिंग द पेशेंट कंप्लेंट्स. क्या था दूसरा जो इशू हम लोग देख रहे हैं आजकल, आपने अखबारों में पढ़ा होगा, आपका बहुत बड़ा हॉस्पिटल है, यहाँ पे पेशेंट कैजुअलिटी में अक्सर आते हैं और अक्सर होता है कि बेड अवेलेबल नहीं है. ये मैं सब प्रैक्टिकल सिनारियो बता रहा हूँ मेरे दिमाग, क्योंकि आज वो लॉ अपना स्लाइड्स तो लेकर के आया नहीं मैं. अब ये रिसेंटली अखबारों में खबर थी कि आप कैजुअलिटी में एक हॉस्पिटल में गया, दूसरे ने भेजा, तीसरे ने फाइनली पेशेंट की डेथ हो गई और 4 हॉस्पिटल के डॉक्टर लपेटे में आ गए. इसका अपना प्रोटोकॉल आप लोगों का बहुत फिक्स होना चाहिए. कैजुअलिटी में पेशेंट को हैंडल कैसे करना है, स्पेशली जिन पेशेंट्स पे एलिगेशन लगता है, खासकर ये पैनल के पेशेंट होते हैं जहां डाउट होता है कि बिकॉज ऑफ मनी एडमिट नहीं किया गया होगा। अगर आप ये क्लेम करते हैं कि बेड अवेलेबल नहीं था, तो आपको डॉक्यूमेंटरली प्रूव करना पड़ेगा कि बेड वॉज नॉट अवेलेबल, अगर कुछ केस होता है। सेकेंडली, कैजुअलिटी में जो लोग पेशेंट को हैंडल करते हैं, उसका जो वर्कअप करते हैं, उसको रेफर भी करते हैं, तो वो कंप्लीट होना चाहिए ऑन पेपर हमेशा। बहुत सारे केसेस आ रहे हैं और ये बहुत बड़ा इश्यू बनता है, लॉ का इश्यू बनता है। मेडिकल काउंसिल में तो हम लोग देख ही लेते हैं, वैसे भी इश्यू बनता है। इस पे ध्यान रखिएगा। मुझे पता है और आप लोगों का तो खैर बहुत अच्छा है गंगाराम का, तो पर कई कॉर्पोरेट हॉस्पिटल तो मैंने देखा है डेलिबरेटली करते हैं सर। हम आप सबके सामने कह रहा हूँ, पैनल के पेशेंट्स को टरकाने की कोशिश की जाती है। हमने इंक्वायरी की तो बाद में मालूम है बेड खाली था। अगर लॉ ऑफ लैंड को फॉलो करना पड़ेगा सर, आप उसको एग्री करें डिसएग्री करें। अगर आपने पैनल के पेशेंट को एक्सेप्ट किया तो आपको एक्सेप्ट करना पड़ेगा, उसको आप मना नहीं कर सकते कि आप पिकम चूज करेंगे। तो इसका ध्यान रखिएगा, इसमें काफी लिटिगेशंस हो रहे हैं। और एक जो डॉक्टर त्यागी ने बात करी भी मेडिकल सर्टिफिकेट्स की, थोड़ा सा बेटा, दो तरह के जो इश्यूज होते हैं, एक तो इंटेंटली गलत होते हैं, एक अनइंटेंशनल होते हैं। इफ द समथिंग इज डन unintentionally in a right spirit, something goes wrong, you are treating a patient in a right way, medical counsel is with you. We go to the last extent to save the doctor because we know that that thing was unintentionally, it was no bad intent. अब बहुत हाईएस्ट डिग्री हम लोग कभी एक्सपेक्ट नहीं करते, वी ऑलवेज एक्सपेक्ट है मीडियोकर डिग्री ऑफ केयर। एट द टाइम आवर एक्सपर्ट्स फ्रॉम एम्स एंड जीबी पंच होते हैं, पर आई ऑलवेज आज देम एक्सपर्ट कि सर आप एम्स के स्टैंडर्ड से मत देखिए, आप उसको मीडियोकर स्टैंडर्ड्स देखिए, देन यू टेल मी। पर अगर इंटेंटली गलत करेंगे तो मामला ठीक नहीं है बस। अगर आप इंटेंटली गलत कर रहे हैं, जो लोग पैसे के चक्कर में हो, हम लोग आपके साथ में नहीं है। इफ यू आर इशूइंग फॉल्स मेडिकल सर्टिफिकेट इन लिeu ऑफ मनी, काउंसिल नॉट सपोर्ट यू। इफ यू आर परफॉर्मिंग some procedure X and writing procedure Y in your notes and discharge because of insurance, ये हो रहा है आजकल काफी। कई केसेस देखे हमने लास्ट ईयर में, आपने सर्जरी करी कुछ पर डिस्चार्ज में कुछ और लिखा है पेशेंट, क्योंकि इंश्योरेंस के पैसे ज्यादा मिलने वाले हैं, एंड में फंस गए। रिसेंटली केस था, बहुत बड़ा केस था, अनएथिकल इश्यूज थे, सरोगेसी और आईवीएफ को लेकर के भी काफी प्रॉब्लम्स आ रही हैं। ओवम किसी का डाल किसी में दिया, किसका किसी में कर दिया। बिल्कुल भी इंटेंशनली गलत काम बिल्कुल नहीं करिए। मैं बार बार रिपीट कर रहा हूँ, अनइंटेंशनली हो जाएगा, मेडिकल काउंसिल आपके साथ में है, इंटेंशनली बिल्कुल मत करिए। और आप लोगों को जरूरत भी नहीं है। किसको जरूरत है बताना जरा। इस हॉल में कोई ऐसा डॉक्टर बैठा हो जो अपनी नीड का कम से कम डबल ना कमाता हो, अपना हाथ खड़ा करते। कम से कम डबल ना कमाता, सबके सामने कह रहा हूं सर। जो हम लोग को जरूरत ही नहीं सर, हम सच ए प्रिविलेज सोसाइटी। जो लोग करते हैं हमारे काउंसिल में कि मुझे इतना दुख होता है, मैंने तुम इस काम करने की जरूरत क्या थी यार, तूने क्या कर लिया। फॉर 10% 20% इनकम ऐसे काम करते हैं। मैं त्यागी होते हैं, वी फील सो सॉरी फॉर द डॉक्टर, और उसमें आप कुछ नहीं कर सकते। वो अगर ऑन डॉक्यूमेंट, तो कभी भी ऐसे काम मत करिए, हमें जरूरत ही नहीं करने की। इंटेंशनली गलत काम मत करिए, अदरवाइज अनइंटेंशनली गलत होती है, काउंसिल आपके साथ में, बिल्कुल क्लियर है। और लास्ट में भी एक कुछ कंट्रोवर्सी रिसेंटली हुई थी, एंड वन ऑफ द स्टेटमेंट मेड बाय आवर ऑनरेबल हेल्थ होम मिनिस्टर इन पार्लियामेंट कि मेडिकल प्रोफेशन इज नाउ एग्जम्प्टेड फ्रॉम क्रिमिनल केसेस। हमने सबने पढ़ा, तो हमने सबने चीयर अप भी किया था, पर उसमें मैं आपको क्लैरिफाई कर देता हूँ, ऐसा कुछ नहीं है। यू आर स्टिल टोटली कवर्ड अंडर ऑल द क्रिमिनल प्रोसीजर। इनफैक्ट अब और पहले से भी खराब हो गया है। वाई आई एम टेलिंग यू, इनिशियली इट वॉज 304A. 304 is say something, if you are causing a death due to the rash and negligent act not amounting to culpable homicide, you can be imprisonment or fine for like 2 years. इस प्रोविजन में कहीं भी मेडिकल प्रोफेशन का नाम नहीं था। इट इज जनरल, एनीवन कॉजिंग डेथ ड्यू टू रैश नेग्लिजेंट एक्ट, इसको एसएच ही मेडिकल प्रोफेशन में लगा दिया जाता था। ऐसे इसको इंटरपोलेट कर देते थे। बट 2 लैंडमार्क केसेस चेंज द सिनारियो। एक डॉक्टर सुरेश गुप्ता वाला केस था वर्सेस गवर्नमेंट ऑफ एनसीडी है, दूसरा जैकब मैथ्यूज वर्सेस गवर्नमेंट ऑफ पंजाब। 2 लैंडमार्क केसेस में, इन दोनों केसेस में डॉक्टर्स के अगेंस्ट 304A लगा के उनको अरेस्ट किया गया था। 1-1 साल के गैप में केस आए थे। 304 सबसे पहले सुरेश गुप्ता केस में लगा था, डॉक्टर वॉज अरेस्टेड, उसकी बेल डिनाई हो गई थी सुप्रीम कोर्ट तक। सुप्रीम कोर्ट ने फाइनली क्रिमिनल केस हटा दिया था। उसके 1 साल बाद जैकब मैथ्यूज केस आया, अगेन ए डॉक्टर वॉज अरेस्टेड, under 304A. Again, in this case, went up to Supreme Court. यहाँ पे Supreme Court की बेंच बैठी थी. अब Supreme Court की बेंच ने बड़ा लंबा डेलिब्रेशन के बाद 2 ऑब्जर्वेशंस आई थी उसकी. That was the 304A. क्योंकि लॉयर लॉबी का कहना था कि सेम लॉ फॉर सेम लॉ यू कैन नॉट हैव 2 सबसेट ऑफ पॉपुलेशंस. एक पॉपुलेशन के लिए आप लगाओगे, एक दूसरे डॉक्टर्स के लिए कैसे छोड़ दोगे. तो सुप्रीम कोर्ट ने कहा था कि यू कैन नॉट चेंज द एसेंस ऑफ 304A, बट वेन एवर यू आर employing 304A for a doctor, arresting a doctor, you must see the degree of negligence should be of very high or gross degree, gross nature. उसके बिना डॉक्टर्स के अगेंस्ट 304A लगा के अरेस्ट नहीं करना है. एंड सेकंड, मोर इंपॉर्टेंट दैट सुप्रीम कोर्ट मेड एन ऑब्जर्वेशन दैट since a police person is not medical expert, before filing a case against a doctor, they will seek an opinion from medical body. अब 304A तो हटा के इन्होंने 3061 ले आए. 3061 में कहीं भी मेडिकल प्रोफेशन को एक्सक्लूड नहीं किया गया है, तो आप अभी भी इंक्लूडेड है 304A हटने के बाद भी. तो ये बिल्कुल भ्रांति में मत रहिएगा कि हम लोग हट गए. सेकेंडली, पहले था इट इज अदर फाइन और इम्प्रिजनमेंट, अब हो गए इम्प्रिजनमेंट एंड फाइन. सो फिर डॉक्टर्स कन्वर्टेड 304 इम्प्रिजनमेंट इज एसेंशियल नाउ, तो दूसरा और ही खराब हो गया है. और तीसरा, अगर 304A हट गया तो सुप्रीम कोर्ट के ऑब्जर्वेशन का क्या होगा, वेयर सुप्रीम कोर्ट हैड सेड कि विदाउट ओपिनियन ऑफ अ मेडिकल बॉडी ए डॉक्टर कैन नॉट बी अरेस्टेड, बिकॉज 304A तो हट गया, एंड दैट वाज स्पेसिफिकली इन टर्म ऑफ 304A. मैं ये सब बातें इसलिए कह रहा हूँ कि दीज आर थिंग्स टू बी पॉन्डर अपॉन. मुझे भी इनका जवाब नहीं पता है, तो लेट अस डिबेट इट, लेट अस सी वेयर दे गो, लेट अस सीक क्लैरिफिकेशन ऑफ द गवर्नमेंट आल्सो. तो ये सारी कुछ बातें थी जो मेरे दिमाग में आपसे बात करना चाहूंगा. अदरवाइज Gangaram Hospitals, I have a very long association. In 1991, I came to Delhi from a very small town called Rewa, and my first job was in Gangaram Hospital. I worked in a nursery for many months here. Then I shifted to other hospitals, and I still have a very emotional attachment to a lot of doctors here. So, best wishes from my part, and let us continue the good work. Thank you very much.
Thank you, sir, for that very, very insightful address. I'm sure it has added to the knowledge of all our delegates. Thank you so much. Well, they say time takes wings, moments are soon gone. The good things never last forever, only their memory lingers on. So as a token of our appreciation and as a token of our memories of this occasion, we would like to give some mementos to our esteemed guests. I request Dr. Jaya Sood to kindly present a memento. So we have sustainable mementos here, in the true sense of the word. Thank you, sir. Thank you, ma'am. I request Dr. Anil Bhalla to present a memento to Dr. Girish Tyagi, sir. And I again thank both our esteemed guests for their presence here. They took out time from their very busy schedule to be with us. I request Dr. Harbans Lal to present a memento to Dr. Jaya Sood. And Dr. Harbans Lal, a memento to Dr. Bhalla. We are also privileged to have with us Dr. S.P. Bayotra, a very, very keen academician who's like a father figure, or his smiling presence has added so much to the occasion. So I request Dr. Harbans Lal to kindly present a memento to him. Thank you so much. Well, this CME symbolizes going from ignorance onto knowledge, and similarly from darkness onto light. So to symbolize this very concept, we have the inaugural lamp, and I request all our esteemed guests to kindly light the inaugural lamp to invoke the goddess Saraswati, the goddess of learning. We all. So, thank you so much for the lamp lighting. So, ladies and gentlemen, the person who has, been behind, the person who's been the driving force behind this CME, the person whose concept this has been, who's been, day in and day out fine-tuning the CME, is Dr. Harbans Lal, the chairman of the CME committee. So I now request Dr. Harbans Lal to kindly propose a vote of thanks.
Good afternoon, friends. I'm really thankful to the Board of Management, and there have been a lot of chairmans and now Vice Chairman Dr. Jasud is here, Secretary Dr. Anil Balla is here, and though Chairman Trust Society Dr. D.S. Rana is not here, and Chairman Board of Management Dr. Ajay Surup is not here, but such is the magnanimity of the Board of Management at Sir Gangaram Hospital. They really don't care whether they are there or not. They said, you go ahead and do the program. Any one of us will be there and do the honors. So really, this is a very good atmosphere at Gangaram Hospital, where there is no differentiation between a member, the consultant, or the people who are in the Board of Management. So all of them are good friends, and they really support each other. So thank you very much to all the members of the board for agreeing to this. And my sincere thanks to Dr. Arun Gupta. He is very busy, as he has already told that already, besides his pediatric practice, and with the 50 to 60 cases coming in a month. So as soon as I called him, he readily agreed to be over here to grace the occasion and giving us the really wonderful insight into it. And Dr. Girish Tyagi, I got no words to praise him. Whenever we need him, he is always there. And so he has been coming to our CMEs earlier also, and always has been giving us insight into the medical legal cases. And most of all the delegates who are here, we started 13 years back, and we continued it because of the tremendous response and interaction and feedback we got from you. So thank you very much. I keep on coming, and we hope to continue it and maybe enlarge it further, as our Chairman Board of Management things that which really make it even bigger than what we are doing now. And I thank my committee members and all the staff of the Gangaram Hospital who has really done a wonderful job of putting this together. So after this, I think now the most important agenda, and that is the lucky draw. And this is the lucky draw for all those who came before 10 a.m. And this is the early bird prize. And this is the air fryer. And so 10 of you will be lucky today to get that. And after that, we will have a not out delegate prize. That means those who came before 10 and those who came afterward also, but those who will stay till the end of the session. So the 10 of the lucky draws will be done. After this lucky draw, we'll have the last session of the day, which will be for nearly an hour or so, 1 hour, 15 minutes, 20 minutes. And after that, we'll have another lucky draw. So I'll request Dr. Tinku. So these are the people, nearly 100 odd people, those who came before 10 a.m. So I request Dr. Arun Gupta to do the honor to take out the slip and to claim this prize. The person has to be present in the hall. If he is not here, the prize goes to the next person. And the Gangaram family is excluded from this prize. So coupon number is 294, Dr. Rajendra Kumar. आप सर मेगा से नीचे आ जाएंगे. आप सभी लोग नीचे आ जाओ. नीचे से निकाल लेते हैं. नीचे से. आज ISC को. I think we need to complain to the ISC who has put up this release stays very badly. देखो बॉल ले दो तो मेरे को निकाल दो. ऐसा कुछ हैंड माइक है क्या? हैंड माइक. सो अपने पहले उसको बुला लो ना जिसका आ गया था. नहीं जस्ट एक डॉक्टर राजेंद्र पहले इनको दे दो. कल हैं बटवा दो. Those who are getting the prizes, they can keep the ticket with themselves. We'll put it back. If they stay till the end, they got a chance to get another prize. So it's not over, so don't tear it even if you get it. Last time there are 2-3 people who got double prizes. नहीं साहब निकालते जाओ, मैं तो अपने पास रख रहा हूँ. डॉक्टर कविता सविता सैनी. Dr. Mukesh Purohit. Is Dr. Mukesh Purohit there? Yeah. What is your last mobile number, last 3 digits of your mobile number? 7217. कोई बात नहीं.
Dr. R.S. Bajaj.
Is Dr. Bajaj here? Dr. R.S. Bajaj? नहीं आपको क्या सपोर्ट दोबारा आ सकता है. R.S. Bajaj is not here. So I'm telling this. Dr. Sukhdas or something. Last.
Coupon number 172.
क्या नाम आप?
फोन नंबर क्या मैडम? आइए.
आइए। डॉक्टर S.K. वर्मा, what's your last 3 digits? Last. ठीक है।
डॉक्टर G.R. सुशीला एंथनी, जो 10 बजे से पहले हैं, फ्रंट लाइन में बैठे हैं, वैसे भी उनका बनता भी है सर। थैंक यू।
डॉक्टर ललित गुप्ता, what is your last 3 digits? 500. Good, perfect. 7 have you done? 3 more. डॉक्टर
स्मिता महेश, इसलिए अगली बार जो है आगे लाइन में बैठे तो ज्यादा चांसेस रहेंगे आपको।
डॉक्टर रुपिंदर कौर, रुपिंदर कौर, कैसे एक और होगा?
कोई नहीं मैडम, ये लेंगे। डॉक्टर C.G. भार्गव, एक बैक साइड से निकाल दिया सर।
So we are going to put them back. So, नहीं ठीक है। 34, 34.
ठीक है
934, ठीक है। So please now stay back for the last session. We are going to put them back. Last note of it. So I request our chief guest and guest of honors. नहीं sir. Doctor, yes.
We have a special gift for our.
Thanks. Okay, thank you. हाँ, इन पौधों को जरा कैरी बैग में डाल दो या दूसरे वाले पकड़ा दो। अरे ये वाले दे दो, कोई भी दे दो ना, ये सब एक एक दे दो। अरुण, एक डॉक्टर अरुण को, डॉक्टर किशन, अरे दे दो ना एक। क्या कर रहे हो, क्या करना चाह रहे हो? पकड़ा दो ना जाके, So now with this we come to the अरे बाकी खाली अभी लोग जा रहे हैं क्या? गंगाराम वालों को बाद में दे देना, पहले इनको जाने दो ना। डॉक्टर गुप्ता गिरीश त्याग भी जान दो, बाकी बाद में चले जाए। हाँ सर, भी आप So now we come to the end of the last session of the day. And after this session, there are 2 sessions, just only 7 talks left. And after that, we are going to have another lucky draw, which will be a mixer grinder. And 10 of them are going to get it. So please be here. And now I invite on this stage Dr. Shyam Agarwal, Dr. Chintamani and Dr. Soumitra Rawat. Is Dr. Chintamani here? So if he is not here, then we have only 6 talks. So Dr. Soumitra Rawat and Dr. Shyam Agarwal, both of them are member board of management, and they'll be chairing this session and taking it forward.
Good afternoon, everyone, and welcome to this CME. So this is one session which is devoted to oncology. So as you heard during the inaugural address, that we at Sir Gangaram Hospital are going to be coming up with a state-of-the-art cancer unit. We're already doing surgeries, we're already doing chemotherapy, but now we'll be adding the radiation wing as well in the near future. So just to say a few words, today in India, almost 14 to 15 lakh new cancer cases are diagnosed. And actually cancer is a lifestyle disease because it's linked to tobacco chewing, smoking, alcohol, obesity, and so many other bad habits which we have in our day-to-day lives. 1/3 of the cancers are actually preventable because they are related to tobacco chewing. Head and neck cancer is the commonest one. 1/3 can be actually cured, and 1/3 you can actually take care of them by palliation and pain treatment. And we have an excellent palliative and a pain care facility available at Sir Gangaram Hospital. There are 5 pillars of cancer treatment today. Surgery, as you know, radiation has been with us now for almost 100 years. So there are 3 pillars which are very important. Chemotherapy, which people dread, which we have been using almost since 1945-46. I think I've been talking about targeted therapy in the last 10 to 15 years, focusing on a variety of cancers. But the 5th modality which has emerged is immunotherapy. And it has actually invaded a lot of cancers, solid cancers, and even hematologic cancers. So I think with these 3 plus 2 modalities, we are able to take care of our patients in a very, very substantial way. Either we can cure them or we can give them excellent quality of life, which we are seeing in our day-to-day practice. So we have actually a couple of talks because Dr. Chintamani is not here. And before I invite the next speaker, I hand it over to Dr. Soumitra for a few words.
I think it's been a long time since we were looking to have a radiotherapy in our Gangaram Hospital, and we are pleased to inform that we are going to have a radiotherapy unit in Gangaram pretty soon. So it'll be a very comprehensive cancer treatment plan. So we had a privilege of having Dr. Huku. You all know he is going to be the chairman and head of radiotherapy in Gangaram, and it's a privilege to have him here. So as Dr. Shyam Agarwal said, that it's a multidisciplinary approach, cancer approach. It involves medical oncologist, it involves surgical oncologist, it involves radiotherapist, it involves palliative care as well in the terminal stages. And Dr. Jaya Sood, she always give us all the support, and the palliative care department and all the kind of pain management is done through her department.
So I think we can get going with this session, and I'll invite consultant medical oncology Dr. Aditya Sareen to the podium. to showcase as to what we have been doing with chemotherapy, immunotherapy, and targeted therapy for patients with advanced cancers. So I think we've been telling year after year that the outcome of patients who have advanced cancers have really changed. You name the common cancers such as breast cancer, colon cancer, lung cancer, hematological malignancies. So I think these in patients, 70 to 80% patients come to us in advanced stages where surgery and radiation may not be possible. But we have to look after these patients, and the paradigm shift is happening, which is what I think Aditya is going to showcase.
So good afternoon, everyone. And obviously the session post-lunch and after so many, niceties that has already been done, I think everybody is now cheerful and alert, because my topic is going to go a little bit fast, because at the end of the day and at the end of the slide, which the point I want to highlight is a very important point. I think all of us now must have a family member or a relative or a patient who have been diagnosed with cancer. I hope the audience agrees. Yeah. Okay, so let's dive into this topic. Do miracles happen in oncology? Well, both terms, miracles and oncology, they are 180 degrees, but sometimes it does. So this is a case of 55-year-old male with diabetes and hypertension who presented to us with weight loss, loss of appetite, constipation, and abdominal pain. On examination, the patient was found to have pallor, and rest of the vitals and the system examination was absolutely normal. And he was evaluated outside for the same. Ultrasound was done, which was normal. Chest X-ray was done, which was normal. And I think here I can highlight just one point, that because of this complaint, the patient, just a second. Yeah, so I think my pointer is visible now. Okay, so endoscopy was done, which showed, diffuse gastric fold thickening with decrease in the distensibility of the fundus and the body of the fundus. I think we can all appreciate these huge rugae folds in the body of the fundus, and this was the main thing for which the patient was having so much trouble. So gastric lesion smears were taken, and it was suggestive of atypical cells and highly suspicious of malignancy. And the final histopath report turned out to be an adenocarcinoma stomach. So with the report, the patient presented to our hospital, and patient had already taken 3 opinions, and in emergency of our hospital, medicine opinion was taken in the medicine department under the guidance of Dr. Beotra and Dr. Gogia sir. They just initiated the PET scan. And once we had the report of the final PET scan, the patient was referred to us for the further management. Now, I'll be going through very, briefly regarding the PET. So, patient was having multiple mediastinal nodes. Patient was having left right renal gland lesion, obviously the primary from the stomach. And you can just see the amount of abdominal nodes, including from left gastric till retrocaval. Again, large and bulky nodes. And multiple bony mets from skull bones, from head to toe. His axial and the appendicular system were both involved. So this was such a worrisome thing for the patient, because patient presented straight away to us in a stage 4 tumor. And once we have these kind of images, like you can just see the nodes, mediastinal nodes, the highlighted one. And if you just see the rugal and the gastric thickening, it's just taking up an SUV uptake. I think it's quite visible over here. Along with that, you can see the bony lesions. It's in a screenshot, you can just see. So at the time of investigation, he was having biocytopenia, hemoglobin of 8.5 and a platelet count of 43,000. LFT was normal, KFT was normal, and echo was normal. So the tumor markers, which we all do it in our baseline setting, CA 19.9 and CA was technically CA 19.9 was sky roof for us. It was 2700. So we got the biopsy reviewed here. Again, it showed a poorly differentiated adenocarcinoma. So these are some molecular tests that we do now in the metastatic scenario, HER2/neu, PD-L1 and MSI, to know whether the patient can have relevance to our treatment like targeted therapy or immunotherapy. And patient was found to have a CPS score of 2. And because in view of the biocytopenia, we had to do a bone marrow as well. And again, bone marrow showed, the biopsy showed the involvement by the carcinoma cell itself. Now, we have a patient, metastatic adenocarcinoma stomach, multiple non-regional nodes, multiple bony involvement, ECOG status is 4. The patient is technically lying on bed, not even moving from till the washroom, not taking food orally, bone marrow involvement is there, anemia is there, thrombocytopenia is there, and extreme weakness is there. I think it paints the picture right now that what kind of patient we were dealing with at the time that we started his treatment. So what does the guidelines say for these kind of cases? They say if your patient has having ECOG performance status more than 3, so for us, the patient was having an ECOG status of more than 4, you just do best supportive care and that's it. Nothing needs to be done. And out of all the treatment, if the patient would have been fit, so this would have been my, armamentarium, these all drugs, 5-FU, platinum and targeted. So I will not confuse you here. So the thought which revolved around us, what should be the ideal next line of management? Should I just give the palliative care and follow the guidelines? Should I discharge the patient for the hospice care? Should I start with the low dose chemotherapy or chemotherapy with immuno? So it was a very tricky situation. And after explaining the family and taking a high risk consent, we started the treatment. We made good documentation of the case. Chemoport insertion was done. Patient was started on chemotherapy along with the immunotherapy, and patient was given cycle 1 on 11th October. And post that, we kept the patient in the hospital to monitor any kind of adverse events. So you can just see that we started with the chemo, immuno, and one for the bone strengthening, we started with denosumab. It's just, I will skip to the investigation. So while he was there, we had to support him multiple times with PRBC, SDP. Again, by the time I discharged him, before discharging, his platelets count were only 63,000, and even at that point, we gave him an SDP and discharged him. So at the time of the discharge, we informed the family they have to do the CBC every 3 days, and because platelet requirement was anyways going to be high, so we started the patient on TPO agonist, and subsequently when the patient came for the second cycle, we just withdrew the TPO agonist, and there were no requirement of any blood products. And now the patient today has completed 4 cycles of chemo and immuno, and there was no adverse event. He improved symptomatically, his veins started to increase, appetite improved, there was no abdominal pain, and now, in fact, after so many doses, he was going to his work, and he was following his all normal routine activities. And post 4 cycles, we can just see there was a significant decrease in the level of reduction of the abdominal nodes, in the neck nodes, and the main stomach primary. In fact, it also just vanished. So if you can just see the October scan, the uptake over here and uptake over here is technically, you just can't appreciate it, even with the PET. Again, the bony lesions over here as compared to over here are gone. Same mediastinal node, gone. So this was a snapshot, and I think we can just see the bulk of the disease over here as compared to here. All the yellow bulb and the yellow light it was taking, it has just gone. So after seeing that the patient is responding good and he has improved significantly, we just continued with the chemo. Until today, he has completed 8 cycles of chemo along with nivolumab. So we have taken this case from an absolute palliative care to a patient where our treatment intents of making sure that the disease control stays. We have just shifted the direction of this particular patient. And you can just see the tumor markers. It's like 45 and CEA is only 1.24. The fall of CEA and the fall of CA 19.9 as the latest report, it's quite evident and significant in the slide itself. If I have a patient with stage 4 gastric stomach, I think only 10% are going to do good only with the chemotherapy at the end of 3 years, and even less number at the end of 5 years. So I will just skip through these. Can I have 1 more minute, right?
Yeah.
Okay. So what combination we used was a chemotherapy along with the Opdivo. It was a trial done on 800 patients, both arms. So it's not a very small trial, it's a big trial done, which ensured us to give the best treatment. It was complemented by giving chemotherapy and immunotherapy. So in the conventional time, it could have been only chemo, but now we started with chemo and immuno for this particular patient. And I will straight away take you to this graph, where at the end of 3 years, only 10% was survival was there. Now with the help of this intervention, we have now 17%. I am able to save more than 5% more patients with the help of the current. Obviously, we need more numbers. I need the graph to be somewhere around 80 or 90%. But I think any number which is better than the conventional standard of care, it does warrant a good amount of reciprocation in the terms of data as well. And what about the response rates? With the addition of immuno to the underlying chemo, the response rates just shot up by 10%. So now with the combination of chemo and immuno, 11% can have technically CR. That is known as complete response. And the patient is falling into that category. Now this was one of those patients, if we wouldn't have, just started the treatment, he would have definitely gone. But obviously after taking due consent and informing the family and taking the family into the confidence, we started this protocol with the hope that we as a team, we have this kind of a response of 47% overall response rates. So the take home message for this thing is that every life matters. Explaining the family members regarding the exact clinical scenario and documentation of the same is very important and critical for us in oncology. And if patient is having low performance status due to the disease itself, we should find a safe and effective ways to tackle the disease burden. So, thank you.
Yeah. So thank you, Aditya. I think that was a wonderful exposition of the role of chemotherapy and immunotherapy in a patient with advanced moribund metastatic gastric cancer. So these kind of success stories are not alone. We are seeing these success stories commonly in patients with metastatic breast cancer, colon cancer, lung cancer. And I think, let me say this, that immune checkpoint inhibitors are there to stay, and we are using them not only in stomach and lung and colon, but almost 30 types of common cancer scenarios which we are seeing.
Absolutely.
So if there is any question from the audience, we are there to answer. Yeah.
Dr. Aditya, I am presuming that this patient was one of the participants of the trial?
No. No.
This is attended to routine practice.
Okay. So when will we have guidelines that will include immunotherapy as well as chemotherapy? Are they already there? Or
So the guidelines are already there. I mean, if I will go just few slides back.
standard of care?
Yeah, this has become the standard of care, the use of immune checkpoint inhibitors along with chemotherapy.
So this is chemo, 5-FU based chemo along with platinum. These two agents are, I think my slide is not visible. Okay. So the chemo along with the immuno is an approved thing. Now we have the data to give chemo, immuno and targeted therapy. And this is all category 1 recommendation. There is nothing category 2 and no confusions about it now.
My question is very on a general practice purpose. If a patient comes to us in OPD, what we should look for as a screening so that we can send the patient or refer the patient to the oncologist on an earlier basis?
So I think,
what we should look for in a symptom?
So I think it's quite simple. There is no hi-fi science behind it. We just have to follow the symptoms. If your symptoms, in a patient are not getting fit in your clinical differential diagnosis, obviously rule out malignancy. Now this patient was not having any lymphadenopathy on the examination. We were just having a pallor. In fact, the conventional investigations, X-ray and ultrasound was absolutely normal in this case. There would have been no definite investigation to diagnose this less than PET-CT scan. So that was the thing that helped us to go and gain the confidence, and definitely the biopsy via endoscopy. That changed everything. So then we know that, we are going the right way.
So, the message to the practitioner would be that if you have a persistent symptom, for example, anemia, fever, weight loss, cough with hemoptysis, or any bleeding from any site. So I think if the symptoms are persisting for beyond 3 to 4 to 5 weeks, you should do special investigations, or maybe you refer them to a specialist for further evaluation.
So currently, it's not recommended for each and every malignancy, but in very, scarce data is there to do it in CA ovary, but even that has not got a category 1 recommendation. Even that recommendation is only till category 3, not more than that. Your clinical suspicion and the family history. You can just screen which of your patients in OPD can have a high preponderance of developing a cancer, and I think that can be elicited only by taking a family history.
So I think, thank you, Aditya.
Yes.
If there is any more. Yes, ma'am.
So if parathyroid cancer is by the name of parathyroid adenoma, well, they are typically benign. And if you have to go with the parathyroid carcinomas, then it generally fits into Men's syndrome. And if you are able to screen the Men's syndrome as early as possible, then the prevention is the best cure. Otherwise, if it is a metastatic parathyroid cancer, then the role of NGS will come, and then the role of TKI, tyrosine kinase inhibitors, can be there. But the practice varies from one doctor to another doctor. There is no such one rule to give you this particular answer. I need to have some answer like the staging and the workup of the patient to better give you the answer in this sense.
So thank you very much for this interactive lecture. We move on to Dr. Soumitra Rawat, who is heading the Department of GI Surgery and Hepatobiliary Cancers. And we're going to talk about surgical advances in the management of GI and hepatobiliary cancers. Soumitra.
Thank you very much, Dr. Harbans for inviting me. And welcome to Gangaram Forum. These are my other affiliation. Royal College of Surgeons of England, where I am a member court of examiner, and I'm a program director of International Fellowship Program at Christie's, which is the largest cancer center in Europe. So my thing is, what is new? I will just take you back few decades ago, and we as a human being, we need to carry on moving forward. So regarding a colon cancer, before the total mesorectal excision came in play, the local recurrence rate was about 60%. So there was a fight for survival. If the patient have a rectal cancer, and if they have a surgery which is without total mesorectal excision, recurrence is about 50 to 60% before 1982. So as you could see, when the surgical technique was changed, the reduction of local recurrence went down below 10%. And in the stage 2 and 3, 5-year survival rate was more than 80%. But what happened, although the 5-year survival was 80%, there was a trouble. There was a urinary dysfunction and sexual dysfunction from 10 to 30%. That is where the laparoscopic surgery came in play. So previously it was an open surgery, there was a modification of open surgery, then there was a laparoscopic surgery. In laparoscopic surgery, you can see the nerves better. In an open surgery, you will put a hand like this and you will damage the nerves. These are the benefits of laparoscopic surgery. So these are the nerves you see. This is during the dissection of inferior mesenteric artery. This is a hypogastric nerve plexus, and this is a parasympathetic nerve plexus which deals with your sexual and urinary function. I think I'm not going to play the video. The specimen which comes out is the same whether you do open surgery or laparoscopic surgery. The scar is so big in open surgery and laparoscopic surgery. It's difficult to see the scar if you appreciate one scar is there, one there, and one there. And this is an incisionless proctocolectomy for multiple polyposis. And as you could see, whole of the large bowel has come out through the rectum, and this is a scars you could see, barely minimal scar, and patient has got a temporary ileostomy which will be taken back to the abdomen in 6 weeks' time. This is after the abdominoperineal resection, where it was a very, very low rectal cancer. We in Gangaram, we did the first robotic ultra-low anterior resection in 2013. This was the first time in North India it was done. Similar is the case with gastric cancer. What you do is a D2 gastrectomy. This is what NCCN guideline also says. And what you do is you take out all the lymph nodes which are associated with the stomach cancer. So these are the lymph node which comes out. I'm not going to go in detail. These are the steps of surgery. And this is what you do. This is a simulation. So you do exactly the same what you do in an open surgery, but you do it laparoscopically, and what comes out is also the same. So these are the, if you can see all the lymph nodes there, and we are taking out all the lymph nodes in cases of laparoscopic surgeries. And again, this is the end result. You could see this is a splenic artery there. This is a hepatic artery. And you could see everything is bare in the whole area. And you could appreciate this is an abnormal left hepatic artery there which has been preserved. And then you do the reconstruction when you are doing a subtotal gastrectomy or doing a total gastrectomy. What comes out again is the same whether you do open surgery or laparoscopic surgery. This is an open surgery. You can see the scar, and that's the laparoscopic surgery. We also do laparoscopic and robotic esophagectomy, whether it's transhiatal, 2-stage or 3-stage. And this is the positioning of the port for the esophagectomy. This is when we are using the robot. And these are the steps, and this is what comes out. This is our gentleman, came in from Afghanistan. This is 3 days after he had a robotic laparoscopic esophagectomy. He's standing next to his bed. And this is a young girl. She had a Whipple's procedure laparoscopically, and this is the picture when she came in the clinic. This is a scar mark after she had a Whipple surgery. You could barely see the scar mark, and she's doing very well. I think problem with new modality is there is enough evidence, guidance, but there is a problem about the training. Not many people are trained. So along with Gangaram, we collaborated with Johnson & Johnson, and we did a lot of training of the young doctors. We started doing a laparoscopic GI fellowship with Christie's. Gangaram became the first center in India to associate it with National Board of Examination, starting the GI and HPB fellowship program. Again, thing is a preceptorship. You go and train other people in the other hospital, and it was a privileged moment that All India Institute, they bought the advanced laparoscopic surgery, but they were needing a guidance for doing the advanced surgery. Me and my team, we were invited to do the surgery in AIIMS. We went there, did it for 4 or 5 times so that, they can start doing it there. So these are the 4 pillars of surgical standard. Quality assurance is important. So these are all my papers and presentation. This is about colorectal cancer. This is about our esophagectomy. We are also using the enhanced recovery program where we take help of all our consultant, and Dr. Jaya Sood is very, very proactive in this, so that before the surgery we optimize the patient and we do the surgery absolutely according to what the protocol says. If patient has got a blood pressure which is not controllable, diabetes which is not controllable, we control them first and then do the surgery. Eventually is the teamwork, and the new modalities are there, but the problem is there are very few experienced surgeons and it's technically challenging. But we are living in 21st centuries, and we should have a surgery which belongs to 21st 21st century. It is not the strongest of species which survive, not the most intelligent. The one who survives is who is most adaptable for change. Thank you very much. Thank you.
Thank you, Dr. Soumitra. Any questions from the audience, please? So I think as we heard, you need radical surgery for curing patients with cancer. And if you can do with the minimal access or with robotic, which we are doing at Gangaram Hospital, I think you can deliver the best. And of course, the second message is that this is all a multidisciplinary approach, because patients after surgery also would require, depending upon their stage, radiation, chemotherapy, immunotherapy, or targeted drugs. So I think we do have tumor board facility at our hospital, which we are doing every week to discuss our complex patients for providing the right decision at the right treatment for the right stage of the patient. So I think with this, if there are no questions, I'll call this session off and move on to the next session. Thank you.
Thank you, Dr. Shyam Agarwal and Soumitra Rawat. And now we'll invite Dr. S. Sukku on the stage, Dr. Rakesh Kaul, Dr. Shikha Haldar, Dr. Mala Srivastava to chair the last session of the day. And there are 4 speakers. Dr. Arpita Gupta is here. Yeah. Dr. Ashwin Malia, Dr. Vimlesh Thakur, and Dr. Deepika Gupta.
So, good afternoon, ladies and gentlemen. So, you have heard about the systemic treatment, the surgical part, and this session will deal with radiation and some more surgical issues in different areas. As you have been informed by, the members of the Board of Management that radiation is coming, and I am here to guide and mentor the radiation team, which will be headed by my colleague, Dr. Shikha Haldar. I'll request her to give you a 2-minute brief about what is coming in radiation here, and then we will take up the,
Good evening, everyone. And in Gangaram, we are coming up with a very state-of-art radiation oncology department. We are getting a high-end linear accelerator that is called True Beam, which is capable of treating all kinds of high-tech treatments such as 3D conformal radiation therapy, intensity modulated radiotherapy, image-guided radiotherapy, stereotactic body radiotherapy, or stereotactic radiosurgery. And there is another machine which is called tomotherapy, which is equally as good as the True Beam linear accelerator, but added to that, it can treat very well the long field such as the total body irradiation. Total body irradiation is a part of bone marrow transplant protocol where radiation is given to ablate the bone marrow, and it has been seen if you incorporate radiation therapy in bone marrow transplant, the graft versus host reactions are less, and the acceptance of the bone marrow graft is much better compared to when you do BMT without radiation therapy. As Dr. Shyam Agarwal has said, like radiation has been around for last 100 years. The X-rays was first discovered in 1895 and then radium in 1898. And the first case was treated in 1903, that is the basal cell carcinoma. And that time also they realized that the skin cancer, which would have left a mark with surgery, was very well treated with radiation without giving any cosmetic disfiguration. So today's our talk is on organ preservation. We'll be kind of highlighting on that, how radiation which can be given as a curative treatment can cure their cancer as well as preserve the function, such as the voice, or the way we give the technique can also preserve, decrease the side effects of radiation, such as the salivary gland xerostomia. So Dr. Arpita will be speaking on that. Thank you.
Good afternoon, everyone. Thank you, ma'am. So I'll be talking regarding preserving function, radiotherapy in head and neck oncology. Head and neck cancers come with unique challenges, and preserving function is one of them. Imagine facing a diagnosis that not only threatens your life, but compromises your ability to eat, speak, and interact with the world like you once did. In the next few minutes, we'll see how modern radiotherapy techniques make a difference. It's not just about getting rid of cancer anymore. It's about making sure that people can go back to normal life after treatment. In our body, head and neck region houses important organs that do important jobs. These parts help us talk, eat, drink, breathe, see, and hear. Let's see how radiotherapy plays a crucial role in keeping them working. In head and neck cancer patients, radiotherapy may be offered as a definitive treatment, that is, as an alternative to surgery, like in most pharyngeal cancers, and sites like lip and hard palate. Secondly, it may be offered as an adjunct to surgery, what we call adjuvant radiotherapy, usually in cancers of the tongue and buccal mucosa. Lastly, palliative radiotherapy may be offered for locally advanced tumors not amenable to curative treatment for symptomatic relief from symptoms like pain and bleeding. When talking about preserving function in head and neck cancer patients, the most impactful has been the possibility of preserving voice. Way back in the 1990s, the Veterans Affairs group assessed chemotherapy followed by radiation as an alternative to laryngectomy in locally advanced laryngeal cancers. They reported a larynx preservation rate of 64% in patients receiving chemotherapy followed by radiation. In the coming years, there was further refinement of the treatment paradigms, and it was observed that concurrent chemoradiation can offer larynx preservation rates of up to 80 to 85%. Here we see a locally advanced laryngeal cancer patient planned for definitive radiotherapy with chemotherapy. This in yellow is this is what we fuse the CT, planning CT with the diagnostic PET CT to aid in treatment planning. And this is how the disease responded at 4 weeks of radiation therapy. The red arrows mark the clearing up of the disease in the region of the epiglottis and also the larynx, with the airway being patent now. The role of radiotherapy is not just limited to advanced laryngeal cancers. Even in early glottic cancers, radiotherapy has been shown to offer better quality of voice at 2 years as compared to other minimally invasive options like transoral laser surgery. Second to voice, swallowing is another important function that needs to be taken care of. Dysfunction of the pharyngeal muscles can severely restrict diet in patients and lead to feeding tube dependency. In our experience, we have seen that patients who need adjuvant radiotherapy after transoral robotic surgery have more difficulty regaining their swallowing function and often have prolonged tube dependency. In patients receiving radiation to the neck region, the constrictors, which you see here in yellow, can be selectively avoided using modern radiotherapy techniques called DARS optimized radiotherapy. DARS stands for dysphagia aspiration related structures. Here is a patient who presented with large nasopharyngeal mass and diagnosed as nasopharyngeal carcinoma with extension to the oropharynx. And this is how this patient responded at 4 weeks of radiation. This is at 4 weeks of radiation. You can see the mass completely clearing up. So what we have talked about thus far is organ preservation using external beam radiotherapy. But for small lesions of the lip and hard palate, even brachytherapy is effective. These images show how thin catheters that are placed in the tumor and radioactive iridium source passes through them, these catheters, and treats the tumor. And this, number 3, is the follow-up image of the patient, an excellent example of preservation of cosmesis and function. This is how brachytherapy is delivered for superficial tumors of the hard palate with a lot of assistance from the Department of Dentistry. Other than organ preservation, modern radiotherapy techniques allow us to preserve function of surrounding normal organs like parotid by selectively targeting only the area to be treated while avoiding radiation to the uninvolved tissue. On the right is what we call the 3D CRT technique, where beams are fired from both directions and both the parotids receive a significant radiation dose. On the left is IMRT, which allows selective sparing of parotid while treating the intended area. This study, published in 2011 in Lancet, clearly established the role of IMRT in preventing xerostomia. It was seen that at 2 years, xerostomia was significantly less common in patients treated with IMRT as compared to conventional radiotherapy, and over time, the recovery was also much, much better. Persistent dryness of mouth affects both eating and speech, while also raising the incidence of dental caries and oral infections. When treating patients, our aim is to see healthy wet mucosa like this on follow-up. And this is how we achieve it, by selectively sparing the parotid glands. IMRT is a boon, especially for treatments of cancer of the nasal cavity and paranasal sinuses. The major challenge in treatment of such tumors is proximity to sensitive structures like the eye, retina, optic nerves, chiasm, cochlea, brainstem, and brain. So this is the target volume for a patient of adenoid cystic carcinoma. Of the paranasal sinuses, and you can see the tumor here sitting right between both eyes. This is how we were able to achieve radiation dose to the tumor, which you see in shades of green, blue, and yellow, while clearly sparing both eyes, the optic nerves, and also the chiasm, seen here in pink. Treatment, when such critical structures are very near, requires daily image guidance prior to treatment, a technique that we call image-guided radiotherapy, abbreviated as IGRT. A short demo of how this is achieved by modern linear accelerators. The patient is lying comfortably on the couch with a customized mesh-like mask to ensure immobilization. The imaging jaws come out and take a snapshot of the patient to ensure correct positioning. Once this is verified and necessary corrections done, the machine moves all around the patient in continuous motion, all the while these fine leaves moving dynamically to conform to the shape of the tumor. The entire procedure takes around 10 minutes and is painless. My take-home message would be that radiotherapy plays a crucial role in head and neck cancers. Preservation of functions like speech and swallowing is feasible by offering radiotherapy alone or in combination with chemotherapy for patients of carcinomas of the larynx and pharynx. Brachytherapy can be used to treat small lesions of carcinoma lip and palate, and use of modern radiotherapy techniques like IMRT and IGRT allows sparing of normal organs like parotid, visual, and the auditory apparatus. A glimpse of the LINACs that our department in Sir Gangaram Hospital house, the TrueBeam STX on the left and the tomotherapy Radixact on the right, along with brachytherapy. They're currently in the process of installation. Thank you for patient listening.
Thank you, Arpita. Initially, I forgot to mention that we also have a state-of-art brachytherapy machine, which can do all kinds of procedures, including intracavity in CS cervix or in interstitial implant like head and neck and soft tissue sarcomas. So if you have any questions.
Thank you.
Thanks, Dr. Arpita. Now, it's my pleasure and privilege to invite Dr. Ashwin Maria, who is a consultant urologist, Sir Gangaram Hospital, and is going to speak about spectrum of uro-oncology. many invasive solutions for urological cancers.
Good evening, everybody, respected chairpersons, esteemed practitioners from Delhi NCR. It's really impressive to see you all sitting so interestedly and participating in the, CME. And I bring greetings from Gangaram Hospital. I'm a urologist with special interest in urologic oncology. And if you haven't visited Gangaram of late, this is a view of it at around sunset. So this is the super specialty block. This is our old block, and this towering block is the new block that we are starting dedicated to oncological services. So somebody in the audience just asked a few minutes back that how do you screen people? How do you pick up early symptoms? So fortunately, urologic cancers can be picked up early by simple, symptomatology, clinical examination, and a few simple investigations like ultrasound and, blood tests. For example, PSA. I'm sure all of you have heard of PSA, prostate specific antigen. How many of you are using it to screen your patients at least after the age of 60? Can I have a show of hands? Yes. So there are specific indications when you do the PSA testing, and there are some when you avoid the PSA testing. For example, during an active urinary tract infection or during a urinary retention, you avoid doing a PSA because of falsely high readings. So if you see what does uro-oncology encompass, so starting from the adrenals there above the kidneys, we have the kidneys here, kidney cancers, cancers of the upper urinary tract, the bladder, and then we move on to the prostate, the urethra, testicles, and the penis. So every organ will give some symptoms when the cancer begins. Almost every time we can detect it based on symptomatology and clinical examination and investigations, simple investigations. For example, most of us, at least, after the age of 40, due to some health screening or something, we are undergoing ultrasounds. So when an ultrasound is done, we see many times that a 2 centimeter renal mass or a 3 centimeter renal mass incidentally is detected. People do not wait till till they have hematuria. Earlier, RCC used to be called the internist tumor because it used to present with so many paraneoplastic syndromes like, fever and thrombocytopenia or thrombocytosis. Nowadays, we are picking most of our renal masses on ultrasound in the mid 40s. Due to ultrasound, which was done as part of the executive health checkup. And then anything from the urothelial tract, that is from the ureters, the renal pelvis, or from the bladder, will present with hematuria. Okay, so hematuria in a person above the age of 50, especially who's a smoker, should never be ignored. Please do not ignore this, just attributing it to UTI or something like that. Please get at least an ultrasound and a urine routine microscopy and a urine cytology if you can to look for malignant cells. Okay. Similarly, prostate, as I said, PSA picks up a lot of cancers early. So in well-indicated cases, as part of screening, you can definitely go ahead and do it. Testicular self-examination helps us detect testicular cancers early, and penile cancers are very obviously, it's very obvious to the patient that they're having some abnormality, but many of them attribute it to, some very common infection or something, or balanoposthitis. So if a persistent penile lesion is there for at least 4 to 6 weeks, it has to be investigated by a specialist. So that's my message from this slide. So as you know, cancers are increasing in incidence, and detection rates are also increasing. So this is the data from the Global Cancer Network, GloboCan. So the lifetime risk of us in India to get prostate cancer is 1 in 125, and some rarer tumors like testicles are around 1 in 2,000 patients, 1 in 2,000 people. So prostate cancer now occupies the 3rd position in the commonest cancers for men in India. So in the world, even as a complete GloboCan data, if you can see, prostate occupies the 4th commonest cancer in the world. So if you come to minimally invasive surgical treatment, so I feel very fortunate to be a part of the urological fraternity, because the way minimally invasive technology has percolated into our specialty, I think very few specialties can boast, because we do endoscopic management, we do laparoscopic management, we do robotic assisted laparoscopic management, and we do percutaneous therapy as well. So if you look at the kidney, we have, robotic or laparoscopic nephrectomy, partial nephrectomy for removal of the cancers. Urinary bladder, we are using, even for diagnosis, we are doing minimally invasive, and for treatment as well, we are using robotic assisted or laparoscopic assisted cystectomies. And prostate, the standard of care in 2023 for, if a person is undergoing surgery for prostate cancer is robot-assisted radical prostatectomy. All other techniques have almost been phased out now. There are very few centers that are still sticking to open radical prostatectomies or laparoscopic radical prostatectomies. In testicular cancer, we are utilizing the robot for RPLNDs, the retroperitoneal lymph node dissections. In penile cancers, we are using it for inguinal and iliac lymph node dissections. In adrenal cancers, we are utilizing it for adrenalectomy, robot or laparoscopic assisted. And for the upper tract cancers, that is the ureter, we are doing nephrouretrectomies using laparoscopic or robotic technology. So the percolation of minimally invasive into uro-oncology is very much there, and we are very happy to serve the population using these techniques in our hospital. So how do we decide whether to go in for laparoscopy or robotics? So as you can see the first picture there, so this is a laparoscopic surgery being done. There are small ports being made and the surgeon is using instruments looking at the screen. Okay, and what is the problem? The movements of the surgeon are not intuitive. So they are counterintuitive. When you move your hand down, the tip of the instrument is moving up and vice versa. So, and you are standing, you are not sometimes in an awkward position, your shoulders get a lot of strain, your knees get a lot of strain. So here comes the beauty of the robot. So we get three-dimensional vision, 10x magnification, immersive technology. You feel as though you're sitting within the human body and operating. There are 7 degrees of freedom. So the robotic wrist technology mimics the human wrist so well that, it's as though you are sitting right next to the organ and operating within the body. Better movements, and the workhorse, the workhorse surgery for radical surgeries in urology is radical prostatectomy. And it's so difficult to do a vesicourethral anastomosis, but the robot kind of changed the game for us. So I think that way we are very lucky that deep in the pelvis we can use the robot to operate. The suturing quality is much better as compared to laparoscopy. The ergonomics for the surgeon. So a surgeon's lifespan, workspan as I can call it. Earlier, probably by 60, 65, many surgeons would start taking it easy. But now I think with, because the skill level is there, the ergonomics are better. I think our generation will see surgeons operating till 75 to 80. Okay. Provided we maintain our good health. So for me, at least I can say that robotics is best suited for suture intensive surgeries where we have to do a lot of suturing. I think robotics plays a great role. So just to give you an example of this, you can see here I'm about to do a vesicourethral anastomosis. I have removed the prostate and I'm using the robotic instruments to start suturing, connecting the bladder, urinary bladder to the urethra. So as you can see, this kind of wristed movements is very difficult to do by open surgery or by laparoscopic surgery. So that's where robotics plays a great role. So just to tell you the components of the robotic system, this is our latest robotic system that we're using called the Hugo Medtronic. So these are the master controls which we use to control the arms. And this is the screen that we are using. And we have to wear 3D glasses. This is an open console system. So what are the benefits of the robotic approach? For the patient, it translates to earlier recovery, lesser pain, shorter hospital stay, lesser blood loss, and earlier return to work. And for the surgeon, I've already mentioned that ergonomics and finer dissection quality, anastomotic suturing is very good. We now have level 1 evidence to prove the oncologic equivalence, that is randomized control trials have been done to prove that robotic surgery is producing as good oncologic clearance as open surgery. So just a bit about the scars. I think Dr. Rawat told you about the scars after open surgery. We do get incisional hernias, unsightly hypertrophic scars, wound infections in obese patients. But this is the kind of picture. You can see the first is a case of robotic cystectomy. We've done a radical cystectomy with an ileal conduit. These are the scars that we have. So after a few months, this is how, if this is not the same patient, this is another patient in whom we have done a robotic radical prostatectomy, removed the specimen from a fan and steel. You can see that the scars are almost absent. This is a robotic radical prostatectomy in which we removed the specimen from the port site itself. So as I can say, radical surgeries we are doing with such, very minimal scars. And our journey so far, inception in robotics was done in the year 2012 at Gangaram Hospital. Our board of management has always been at the forefront of introducing new technology in our hospital. First, with the intuitive robot, we did close to 1900 cases from 2012 to 2023, with around 70% being from urology. And now we have the Medtronic Hugo robot. We've done around 170 cases with 76%, and we are happy to we are happy to see that our colleagues from general surgery, GI surgery, gynecology are getting more and more involved in the robotic journey. And this is the audit of our last 100 robotic radical prostatectomies we have done. The mean age of 67, mean PSA of around 14.5. Blood loss, here you can see just 125 ml mean blood loss per robotic prostatectomy, which at one point of time used to be 700 to 800 ml in open surgery. With a mean hospital stay of 2 days, 8 days later we removed the catheter. They are achieving, around 84% of our patients are achieving social continence. That is, they just need one safety pad, because prostate surgery is always criticized for producing incontinence. So let me dispel that myth here, that within 45 days, 84% of our patients are just wearing one safety pad throughout the day, because they will have some stress leaks when they are coughing or laughing loudly. That's it. And we have mean PSA at 2 months of 0.08 and PSA of 0.12 at 1 year. Margin positivity is a problem, but most of them are unifocal margin positivity, which don't require adjuvant radiation right away. But we are happy to have our radiation oncologists and medical oncologists on board to take care of all that if the need arises. So to sum up, moving forward, we see a very strong position of minimally invasive surgery, especially robotics in uro-oncology. Robotic technology has early recovery benefits and lesser blood loss for the patient. World over, more than 95% of radical prostatectomies, which is the most common uro-oncologic surgery being done as of now, are done robotically. And at SGRH, we provide the complete spectrum of robotic surgeries in urology and uro-oncology with excellent results. Thank you very much.
Thanks, Dr. Malla. You have nicely shown how robotics can help in the urological cancers. Any questions from the audience?
I think they're spellbound.
Thank you. Thank you, Ashwin. May I now like to invite Dr. Bimlesh Thakur. He will be speaking about the changing paradigms of surgery in carcinoma of breast. Dr. Bimlesh is consultant with my team. And we know in the earlier times when we had CA breast, carcinoma breast, even in very, very early stages, we used to do extensive surgeries. Bereft the chest wall of all the muscles, do the neck dissection, axillary dissection. But today everything has changed and we have constructed field of surgery and we are achieving equally good results and cost misses. I think Dr. Bimlesh will expand on this whole explanation and speak lucidly.
Good afternoon, respected delegates and respected chairpersons, and I thank the organizing team to invite for this talk. And so my topic today is to discuss about changing paradigms in the surgery for breast cancer. Because I come from surgical oncology department, I will be talking majorly about surgery. So these are the points which I will discuss today. So the role of surgery, the first and foremost, in breast cancers, the surgical part cannot be obviated because surgery forms the most important and integral part of breast cancer treatment. And like other cases where organ preservation is still is being considered, in breast cancer, the surgery forms an integral role. Along with chemotherapy and radiation therapy, it consolidates the role. So, coming from the Hallstadian's principle of radical mastectomy, modified radical mastectomy has already found its place in the as the standard of care in treatment of breast cancer. Now we will discuss about the breast conservation. So it has been proven time and again that removal of entire breast is not required, and even the SSO and Astro panel has concluded that the removal of the complete breast tumor with an adequate margin of 2 millimeter in DCIS and no ink on the tumor margin is adequate and confers equal survival benefit as shown in this graph. So in breast conservation, the incision can be taken along the Cresel lines or Langer lines, and some surgeons prefer doing it in the radial fashion also. And after excision of the tumor, it is closed primarily. So in breast conservation, radiation therapy forms an integral part of its treatment, and it is a must to decrease the local recurrence. Without radiation therapy, breast conservation surgery cannot be, is not equivalent. And rate of local recurrence has been found almost equivalent to the mastectomy. And it has been seen various trials as well as in the cooperative group trials observations. And one point to consider is that 70% of the ipsilateral breast tumor recurrence occur within the first 10 years in the breast conservation group. However, after mastectomy, local recurrence, if at all it has to happen, and it happens within the first 3 years. So after breast conservation, surveillance up to 10 years and maybe 15 to 20 years is required. So these are the various randomized trials which have proven time and again that breast conservation is equivalent to the breast total mastectomy. So careful patient selection is an integral part of considering patients for breast conservations. And these are the absolute contraindications where pregnancy and persistent positive margins if are obtained more than 2 times, and inflammatory breast cancers and diffusely appearing calcifications on mammogram are absolute contraindications. So how do we expand the candidacy of breast conservation among all the patients? Neoadjuvant chemotherapy has the greatest advantage of affording more patients to conservation as compared to the mastectomy, and it has been used now in early breast cancer also. Oncoplasty is combination of the oncological principles with the plastic surgical principles combined together during the same procedure. And it expands the candidature of the breast conservation population. So this slide shows the lateral thoracic artery perforator flap, kind of oncoplastic procedure which affords a very good cosmetic outcome as well as an oncological benefit. This shows a mini LD flap in breast conservation used, and the other picture shows an inferior pedicle flap in breast conservation. Round block oncoplasty in this non-palpable lesion has been used here to afford the equivalent benefit of breast conservation here. This is a lateral matrix oncoplasty. And post-mastectomy, after mastectomy also breast reconstruction can afford an equivalent quality of life. So here skin sparing mastectomy can be done, and with the reconstruction options like LD flap here is affords equivalent quality of life. Nipple sparing surgeries can also be considered in appropriate selected patients. And nipple reconstruction along with the breast reconstruction can also be done in the same stage, affording good cosmetic advantage also. So now we will talk about the axillary management of the axilla. So conventionally, axillary lymph node dissection was the norm and the standard treatment in breast cancer surgery, but it was not it was not afforded without any complications like lymphedema, which is a major dreaded complication, and it affects around 30 to 50% of the patients who undergo axillary lymph node dissection. So sentinel lymph node biopsy is a technique by which we can avoid this dreaded complication, which has allowed us to decrease this rate of complication to 5% to almost nil. what actually is being done in sentinel lymph node biopsy is the injection. We inject a dye along the tumor, which travels along the lymphatics to the first lymph node, first draining lymph node, which is called sentinel lymph node. And that sentinel lymph node is identified intraoperatively, and only that targeted dissection is done to isolate 2 to 4 lymph nodes, and intraoperative frozen section analysis helps us in detecting whether there is presence of tumor cells in these lymph nodes or not. If the lymph nodes don't harbor any tumor cells, it can be assumed that the distant lymph nodes are also sterile, and axillary lymph node dissection is not done. If we find tumor cells in these sentinel lymph nodes also, then axillary lymph node dissection has to be done completely. So there are various techniques of doing sentinel lymph node biopsy, like blue dye, radiocolloid, technetium-99 dye, and ICG also. So this same technique has also been used in skin cancers like melanoma, squamous cell carcinoma, and appropriately selected head and neck cancers, and penile cancers, and endometrial cancers, which have not been shown in this slide. Next, I want to discuss about the presence of occult breast cancer, which are not palpable clinically, but are detected during mammography. So after increasing use of screening mammography, we find more and more radio-occult disease, clinically occult disease, which we have found on mammography only. So there are several techniques of localizing these tumors and excising it completely. The wire-guided localization is the gold standard in this, and the most cost-effective. And why I am talking about quality of life? Because female patients report better mental well-being as well as better sexual well-being, and better body image issues after conservation surgery as compared to the mastectomy. And this has to be always talked about, and because trauma of waking up without a breast is a huge nightmare for any woman. And we routinely use breast Q questionnaire to estimate the quality of life, also apart from discussing the length of life. So to conclude that, I need to stress upon the fact that surgery forms an integral part of breast cancer management, and breast conservation should be offered to all the patients which are candidate for that. And we can expand the candidacy of breast conservation by neoadjuvant chemotherapy and utilizing oncoplastic techniques. Post-mastectomy breast reconstruction should also be offered to the patients, so that they achieve the best quality of life. And sentinel lymph node biopsy is this recommended method in in most of the early breast cancers, and occult breast cancers, which are increasingly being detected, should also be addressed by surgical localization, and MRI breast is a good screening method for that also. And we should always discuss the quality of life in treatment of the breast cancers. With this, I would like to conclude that, and I'll welcome any questions at all.
Thank you, Vimlesh.
Sir, whenever we are concerned about axillary lymphedema, we have to prevent this lymphedema rather than treatment, because we cannot reverse the lymphedema once it has set in. We have to always take care of the ipsilateral arm, like no injections, and no injections or pinpricks should be done to that limb. And we also have to counsel the patient that no sample should be taken, and blood pressure measurement should also be should be avoided in that limb. So with that education, we can avoid the lymphedema. But once it has set in, there are several methods by which we can minimize the effect and help the patient, which include the physiotherapy treatment options are the most well used: multi-layer compression bandage and manual lymphatic drainage. It has to be taught to the patient very well, and with this we can decrease the morbidity of lymphedema. And there are several surgical options also if these preliminary management options fail.
Can I ask you a question?
Yes, ma'am.
Is there any role of radiotherapy in lymphadenopathy due to breast CA?
If there is lymphadenopathy due to breast CA, the role of radiotherapy is definitely there, and it forms a part of adjuvant treatment after surgery. So, surgery in isolation is not the treatment of breast cancer. So, radiation therapy along with chemotherapy, it has to be a multimodal approach for the treatment.
Actually, wherever we are going conservative in surgery, radiation is actually supporting that conservation, and breast conservation is the perfect example of that. But the only thing is that when the surgeons operate and offer conservative breast surgery, patients should be told beforehand that all of you will have to undergo radiation, because many patients who come to us, they say that before the surgery was done, I'm not talking about
exactly.
the oncology professional, but many surgeons outside, they don't tell them that radiation will be required. It is a surprise for them.
Exactly. That's why I mentioned that appropriate patient selection is important.
Vinesh, can you tell about the small tumor, say 2.5 centimeter, 3 centimeter tumor, which is triple negative or HER2 positive? Will you operate first, or will you want chemotherapy to begin?
As I mentioned earlier, even in early breast cancer, now we are resorting to neoadjuvant chemotherapy, that is chemotherapy before the surgery. So the advantage, what we found here is that giving neoadjuvant chemotherapy, it doesn't help much in the surgery, but it does give us a lot of information about the prognosis and later management after the surgery is done. Like achieving complete response, if the patient has responded to the neoadjuvant chemotherapy, it gives us a very good prognosis that the patient will do very well after the surgery. And if there is still residual tumor after completion of neoadjuvant chemotherapy, there are methods to decrease the to increase the survival of the patients. Like in triple negative breast cancer, we often offer an year of capecitabine treatment after completion of the chemotherapy also.
Thank you, Dr. Vimlesh.
Thank you so much, sir.
May I now request Dr. Deepika Gupta. She will be speaking about gallbladder cancers, how to identify and treat it correctly.
Good afternoon, everybody. So mine is the last talk. I'll keep it short. I'm Dr. Deepika. I'm a surgical oncologist at Sir Gangaram Hospital. And gallbladder problems related to the gallbladder stones is a fairly common thing. We have somebody who we know who has been operated, has undergone a lap cholecystectomy. It's a very, very common surgery. And how do we differentiate whether this is a simple gallstone and a simple lap cholecystectomy is going to suffice, or whether it can be something more sinister? It can be a cancer, and what is the difference in the workup and what is the difference in treatment? So we'll be talking a little bit about all these things, but we'll focus more on the surgical management and what are the other modalities of management. So India has this Indo-Gangetic belt which has a very high incidence of gallbladder cancer. I did my training in surgical oncology in South India, where gallbladder cancer was nowhere to be seen, and the only patients we saw were who were coming from North or Northeast India. So, but the Indo-Gangetic belt is blessed with that. And so let us look at the few risk factors. A fat 40 female who's fertile, all these are risk factors. So age is a risk factor, gender is a risk factor, the geographical location is a risk factor. And then there are some other risk factors like having gallstones. So gallstones is a fairly common problem. Everybody who has gallstones is going to have cancer. We can't say that. But among all those who have cancer, gallstones are fairly common. So that is something we need to be careful about. Then it is said that there are some toxins, smoking and alcoholism may be related to gallbladder cancers. And What about the symptoms? So we all know that cancer is no longer a disease which we see only in movies. We know it is fairly common. We all want to identify it early and then treat it correctly, which is the title of my talk. So the symptoms of gallbladder cancer are very vague in the early stages. It just presents like a gallbladder stone. There is some pain in the right upper quadrant of the abdomen. There may be some dyspepsia, indigestion, sometimes an occasional episode of vomiting. And as and when the disease advances, there are very severe features like there's jaundice, patient will come with scratching, not able to sleep at night, there's going to be severe weight loss, there is anorexia, there's complete loss of appetite and general decline of the well-being. So when all these things start happening with a gallbladder lump, that automatically tells us that the disease is a little too advanced. So any features which are suggestive of gallstone disease can actually be a gallbladder cancer, especially if the age is beyond 50. So how to identify? So first step is, as we saw in the history, in the history, if there's any weight loss, if there's loss of appetite, and there is a decline in the performance status, then we need to think, yes, that there is abdominal distension due to ascites. It could be cancer. During examinations, we look for a supraclavicular lymph node, we look for ascites, we look for a gallbladder mass or a hepatomegaly. So ultrasound. Ultrasound is a very, very common test done, and just as we are picking up renal masses, we are also picking up gallbladder stones, and there are certain specific things we need to look for on the ultrasound. So yes, there's a stone, but there's also a polyp, or there are multiple polyps, and they seem to be very thick-walled. If the gallbladder thickness is more than 1 centimeter, it is a very clear-cut indicator that this could be a cancer, and this needs to be evaluated more and operated at a center which is equipped to handle cancers. There can be infiltration of nearby structures, there can be involvement of the liver, there can be involvement of the duodenum, or there can be surrounding lymph nodes are enlarged, or there can be ascites. Ascites, again, is a feature of advanced disease. So what are the blood tests to look for it? Yes, you do a liver function test. Again, there's jaundice. That means it could be that there are multiple nodes which are compressing, or the tumor has grown and is obstructing the bile duct. Tumor markers are not very, very specific, but yes, there's a role to tell what is the local stage of the disease. So once you are suspecting something on the ultrasound, you go for a CT scan, you go for a triple phase, you go for a PET CT, and look for all these features. What about FNAC and biopsy? FNAC biopsy in a early localized gallbladder cancer is not recommended. This is because you will cause seeding from the disease. But if the disease is already advanced, if there's already ascites, there's a supraclavicular node, it's metastatic, yes, you will take a biopsy, prove it to be cancer, and then go ahead with the treatment. So surgery, it can be a simple cholecystectomy, it can be a radical cholecystectomy. Simple cholecystectomy only for very, very early disease T1A, and everything else merits a radical cholecystectomy. Other than that, there's chemotherapy, immunotherapy, radiotherapy. So yes, the procedure is, first is a diagnostic laparoscopy. You look whether the gallbladder cancer is metastatic or not, because it has a tendency to show some peritoneal disease, which may be only picked out at the time of surgery. If there's peritoneal disease, there is no point in removing the gallbladder, because you will not get any survival benefit. Then the second thing is, you go and you mobilize the duodenum, the hepatic flexure, you sample the interaortocaval node and see whether this node is negative for cancer. Again, if this node is positive, it is metastatic, surgery is not going to really benefit, patient should go for a chemotherapy. But if this node is negative, then we go for a complete lymph node dissection, and this is how your surgery will differ from a simple cholecystectomy. You are going to you are going to remove all the lymph nodes which are there along the hepatoduodenal ligament and along the common hepatic artery. You will clip the cystic duct, ensuring that the margin is negative. Then you're going to complete your lymph node dissection. So the stations involved are station 12, that is your hepatoduodenal, station 8, which is the common hepatic, and you aim at least to remove 6 lymph nodes along with your specimen. Then the second part, how it is different from a simple cholecystectomy, is liver resection. You remove the gallbladder with a 2 centimeter margin, so that if there is any infiltration, everything, you end up with a clear negative margin. So this is how your surgery is different, and this is how your specimen should look like. So this is the short video, and I don't think I have the time, so I'll just go to the next slide. So points to note are you need a negative cystic duct margin, you need to do a good lymphadenectomy, you need to see that your bile duct is free of tumor, and point on laparoscopy, you need to avoid any bile spill inside, and also remove the specimen through a endobag if you're dealing with it laparoscopically. A little advanced cancers are dealt via the open surgery still. So this was about early disease. If the disease is well localized to the gallbladder or there is some slight invasion, if it is very, very locally advanced, you think you will not be able to get a negative margin or the nodes look inoperable, you can go for neoadjuvant chemotherapy and then reassess your patient after 4 cycles. If the disease is resectable, you go for a surgery. For metastatic patients, we do not have much to offer from the surgical side. Yes, there's chemotherapy, there's immunotherapy. Another thing that is important and worth mentioning is the jaundice in gallbladder cancer. So gallbladder cancer patients may present with jaundice, and to relieve that, you may sometimes need a ERCP, sometimes you may need a PTBD stenting. One more thing, last point. So if you have an incidental diagnosis of gallbladder cancer, somebody went and underwent a lap cholecystectomy, it was an uneventful surgery, you've recovered well, but now the histopath is showing a cancer. If it is very, very small cancer, limited to the lamina propria, that is, it is T1A, this much is enough, this surgery is enough, you need to be under follow-up. But if it is more than that, you need to undergo a redo surgery. You need to come to us, we will appropriately stage you and decide for the redo surgery or chemotherapy, whatever is required. So thank you, and I'm very much on time. Yes, sir. So as the duration of gallstones increase, so it is said that if you have had gallstones for 20 years, the percentage becomes very high, but there's no such number that I can quote for you right now.
So thank you, Dr. Deepika. I think we discussed with you and shared with you what is happening in modern day in some areas of cancer. You and your patients have experience with the excellence of surgical disciplines at Gangaram. They have the experience of high-end medical oncology at Gangaram, and very soon we will offer you high-end technology in radiation in the most experienced hands in this part of the country and around. So thank you very much for coming.
Thank you, Dr. Hukku, Dr. Shikaldar, Mala Srivastava, and Dr. Kaul. And we are really at Gangaram Hospital. I've been there for now nearly 40 years. And this was the one lacunae we had. So we're really very excited about it. Now for the last part of the lucky draw. So this will be a mixer grinder. I will invite Dr. Shyam Agrawal, Soumitra Rawat to please do the needful. And the now audience who have been here since morning, I hope to see that who are the lucky one who get the next 10 prizes.
Dr. Manoj Kumar Prasad. Yeah, he's there.
Doctor UPI.
UP or Lipi?
Lipi, I think. Dr. Lipi. Is she here?
No. Dr. Bhaskar Narayan. Yes.
Hello.
Shekhar. Dr. Vinay Rawat, is it?
Vinay Rao.
Last digits are 543 of the phone number.
Dr.
Dr. MP Gandhi. Congratulations, sir.
Yes, sir.
Third time today itself, or third time?
13 years.
Every year.
Come next year as well, sir. Most welcome. Dr. Hira Lal Kanjru.
Yes, sir. Dr. I.J. Gulati.
JJ Gulati.
Dr. JJ Gulati.
Dr. Pankaj.
Pankaj. Dr. Pankaj.
Dr. VK Jain. A lot of people have left. VK. 9911, the last four digits. Dr. Ashok Kumar Kapoor. Dr. Archana Gupta. Dr. Archana. Dr. Atul Verma.
Atul Verma.
Shake it well,
Dr. R.K. Tuli. Dr. S.S. Tomar.
Dr. Charu. Dr.
Manoj
Pabrai.
Pabrai. Dr. Yasmin.
Yeah.
I think it was our luck that so many people have actually gone, otherwise you would have not got it.
Congrats, Doctor.
इधर
आ जाइए ठीक है
Dr. Mrs. J.L. Anand, I think. 251, last number. Dr. Satyavir Singh.
Yes, sir.
Dr. Dheeraj Mehra.
Dr. Satyavir Singh. No, sir.
Dr. Lily Khosa.
Ladies are there. Dr. Vaishali Verma. Congrats, ma'am.
जब 10 हो जाए तो बता देना भाई. Dr. Sandeep Duggal. Dr. Preeti Chabada.
नहीं प्रीति चावला तो हमारे गंगाराम की है. डॉक्टर विजय मित्तल, डॉक्टर आई.एस. जैन, डॉक्टर ए.के. दत्ता, डॉक्टर ए.के. दत्ता, डॉक्टर वीना मेहता आहूजा, डॉक्टर आशा गांधी, so I think it is the day of the ladies actually, it looks like.
Ladies are more patient and sensitive.
Yeah. डॉक्टर आर.एस. चंदना, जॉली, डॉक्टर जॉली,
डॉक्टर जॉली बगई, डॉली, हाँ. डॉक्टर चांद सेठी,
डॉक्टर चांद सेठी, डॉक्टर विनोद कुमार
गौतम,
गौतम,
गौतम, गौतम.
What is your last digit number?
990.
Dr. K.K. Jain.
सर इसकी इंपॉर्टेंस बता दीजिए जो आपने डाला हुआ है. इसकी इंपॉर्टेंस बताइए आप.
बस ये अयोध्या वालों के लिए है.
तो जय सिया राम.
So now 9 are gone. And now let's see who is the last person like you are over here.
अच्छा, you're there.
Dr. Sachin Kumar Sharma. डॉक्टर सुखदास, ये तो पहले भी नहीं थे मेरे ख्याल से. डॉक्टर वीना पांडे,
सुखदास था.
What is your last digit number?
Yes. Wow, she got both. Congrats.
मैंने वो बोले hair fryer and mixer grinder both are kitchen is complete now.
Yes.
Okay, thank you. Bye bye. See you next year again.